Good morning, I'm Jessica Lovell. Today we bring you an encore presentation of one of our very favorite programs. We'll still be live with you this summer, Monday, Wednesdays, and Fridays, and then come September, we'll be back with our regularly scheduled programming. Until then, enjoy this encore presentation and make it a great day.
I'm Dr. Steve Stites, Chief Medical Officer at the University of Kansas Health System. Welcome to my favorite episode each month. I mean that. I love this show, Show Me the Science, where we dive into the research. Our topic today involves your heart. We all know what a healthy heart is supposed to sound like, and that's this. But have you ever heard one of those sounds whose heart maybe sounds a little wrong, like this? Okay, that sounds kind of cool and groovy, but that's not a normal heart sound. That is the sound of an LVAD, a left ventricular assist device. These are tiny machines implanted, wait for it, inside the heart that literally pump blood for your heart. Today, we're going to talk about why patients might get one, plus the newest data proving how well they work. Everyone watching live can ask questions. Drop them into the chat feed on YouTube, Facebook, Twitter, or email. That contact info is on your screen. Let's meet our specialists this morning who are going to help us learn all about LVADs. Again, left ventricular assist devices. First, Dr. Matthew Danther is the Surgical Director of Cardiac Transplant, as well as the Director of Mechanical Circulatory Support here at the health system. And Dr. Zubair Shah on my right, he is a heart failure and transplant cardiologist and Medical Director of the health system's LVAD program. These physicians are part of a very busy cardiac team here at the University of Kansas Health System. Last year, the health system set some important records with 48 LVAD surgeries and 47 heart transplants. That's 95 very serious, very complex surgeries in a calendar year. I think one weekend we did like 3 transplants. It was a little crazy. Before we begin, I want you to hear from one of our patients who described what it's like living with one of these devices. 78-year-old Richard Lorenz lives in McPherson, Kansas with his wife Anita and with his LVAD, which he got about 5 months ago.
My name is Richard Lorenz, and I have an LVAD. With heart failure, it sneaks up on you. It was something that took place over time, and I think you kind of adapt to the changes. So I don't know that I actually noticed that I was getting tired.
We saw that. The tiredness, sat down. Every time he sat down, he slept. I did not realize he had gotten as gray as he had, but other people had made comment to us, especially after the surgery. My goodness, you have such good color now.
You have a HeartMate 3, right?
Yep.
And what speed is that running at?
At 5,400. There's changes that happen to you, you know, at night. When I go to bed, I'm plugged into the wall. It's kind of fun to watch the picture, so. I have a battery over here, another battery over here. The wires come out of the battery, go into the controller. The controller has a lead here. It goes down and around and into my belly. I wouldn't be able to get on an airplane probably without a lot of scrutiny.
I'll make sure when Dr. Roldan, who you'll meet today, yes, she's super great.
My name is Tess Rosbarski, and I am an LVAD coordinator at the University of Kansas Health System. You met Anita, and she wants to do everything perfect for him, and then Rick is just chill, breezy, easy to get along with as well. They're a great dynamic duo in my eyes.
The LVAD team, of course, went through everything with me numerous times. Tess has been an awesome help to us and explained all the things we had to do. It's real important to keep the line clean and dry. I have to check on it to make sure there's no infection or anything showing.
Just from the moment I met him, I could tell, like, these are going to be fun people for me to work with, but also just genuine people, and they wanted more years. The big thing, they wanted more years with Rick, so I'm glad they did it.
God's given us more time.
I'm 78 years old, and I've lived a long life. I mean, relatively long anyway, but I wasn't really ready to hang it up yet.
That is such an awesome and amazing story. Richard is back working, get this, as an airplane mechanic. He is looking forward to spending more time with his 8 grandchildren and 6 great-grandchildren. That is a really amazing story. Now to the research. We're going to talk a little bit about what these LVAD machines really are, and we're going to start with looking at the biggest LVAD study ever and how patients are doing 5 years after having it put in. The study is called Momentum 3. It involved more than 1,000 patients, and the original goal was to see if a new type of pump was better. The new pump is called the HeartMate 3. Get this, it's a centrifuge that levitates on magnets as it spins and pumps blood. Well, spoiler alert, the newer pump does turn out to be better. Dr. Shaw, you brought one of these new pumps. Show us how the old one and the new one works, and talk to us about why I get to have, if I had one of these, I'd be levitating and magnetizing my body.
Thank you, Dr. Stites. So I have the old pump here. This is a HeartMate 2. As you see, it's an eggshell pump, not used anymore. The Momentum 3 trial compared this pump with the HeartMate 3 pump. Eggshell pump, it sucks the blood out of LV in an eggshell fashion.
It comes out of the left ventricle, it goes in that.
Yes.
So just to say really quickly, the heart's got a couple parts to it. It's got a atrium, and the ventricles are the bottom part, and the left of the side of the heart, the left ventricle, pumps the blood from your head to your toe.
That's right.
And so when your heart's not working right, it doesn't pump the blood, so you don't perfuse your noggin, and you may not perfuse your kidneys, your liver, and all these other vital organs.
And brain, yes.
And then so then what happens here is you're getting help pumping the blood. Is that right?
That's right, Dr. Stites. So this pump will aspirate or suck the blood out of non-functional LV, the LV that's not able to pump the blood out of the heart. So it will bypass the left ventricle, suction the blood out of the left ventricle. The flow is axial, as I said. It will go straight through the outflow graft into the aorta. So the new pump is HeartMate 3, state-of-art pump, only pump that's in the market right now. The reason being complication rates are extremely low, especially stroke. So this is a centrifugal pump. As you see, the inflow cannula goes into the LV. I don't know if you guys can see it. It's here. This is LV. It's not able to pump squeeze the blood out into the aorta, so this will bypass the LV, aspirate the blood. The blood will move in a centrifugal fashion, and the technology, as you said, is magnetic, meaning there is less contact of blood with the pump itself. And it will aspirate the blood. We have an outflow graft here. It was shown in the previous picture, and this will force the blood into the aorta and then to the kidneys, heart, and all other.
So let me get this straight. This is basically a sump pump in your chest, is what you're saying to me. It's a sump pump.
Absolutely.
And what's happened with the sump pump is that the left ventricle normally squeezes about 60% of the blood out and goes to your brain, to your toe, and all that. And when it doesn't pump it, maybe it just kind of sits and quivers or squeezes like 10% or so, because I know that's about, you guys start, you get 10 to 20%, man, we've tried all we can, we're going to have to help it out. And this essentially says, I'm going to bypass all that, and I'm going to go ahead and let this pump take the blood out of the ventricle, which isn't moving like it should, and push it back into the heart and out to the body.
That's right, Doctor.
Okay.
That's simple.
Now, I remember the old Jarvik 7 guys, or the Jarvik hearts that were put back in. Oh, stop it, Williamson. Tim Williams is our medical director, our vice president of infection. I said it wrong. Vice president of quality and safety. He's here as Hawkscott. He's laughing at me because I remember the Jarvik 7 pictures on CNN when I was very old, very young at that time. But this is considerable advance, right? This is like the best thing ever.
That's right, Dr. Stites. I mean, LVAD technology has come long way. As you said, Jarvik hearts in the 80s. Patients used to stay in the hospital 2 months, and outcomes were not as good. But these days, we have excellent surgeons like Dr. Denter. Our average length of stay has been 5 to 7 days. I would say 7 days, just to stretch it, and they go home. And as our patient, as you said, they are able to go back to their work, to their lifestyle, and can do everything else.
The old Jarvik thing, they had a suitcase they carried around that was actually the pump.
Mini refrigerator.
Yeah, and they didn't live particularly long. So Dr. Danter, talk to us about it. How hard is it to put one of those things in the chest? Because this is what you do, right? You put you put the centrifuge onto the heart.
Right. I think
so it can levitate.
I can't overstate what Dr. Shaw said. I mean, this is a paradigm shift in the sort of technology and the tools that we have to treat advanced heart failure, which is a horrific disease. I can remember before the HeartMate 2 came out, and then subsequently how the paradigm changes and improvements with HeartMate 3, that there were not as many options, and the options we had were not as good. People had to stay in the hospital; they couldn't get out. Mr. Lorenz is a great story. He'd had previous heart surgery as well, and he was 78 at the time of his VAD, and he's done exceptionally well. And I think that's the whole purpose.
So how are patients doing? Talk to us about the 5-year survival and what's going on with this cool news, this amazing new study, the Momentum 3.
Well, I think, as you can see on this figure here, I think what the 5-year results of the Momentum 3 trial show us is how far we've come in a little over 20 years. If you think that in 2001, the rematch trial came out, which was really the first definitive LVAD study, our 2-year survivals in the LVAD group were 23%, and the optimal medical management group were 8% survival at 2 years. Now we're talking about 2-year survivals from the HeartMate 3 of almost 80% and 58% survival for patients at 5 years. It is very difficult to come up with an intervention or a medical therapy or a surgical technique that has improved survival in a group of patients whose survival rate is absolutely abysmal to this degree. It is nothing short of a paradigm shift in the therapies that we have to treat heart failure.
So let's back that up for just a minute. So 3 or 85%, is that what you said?
No, so for Momentum 3, which is really the gold standard trial for which we can refer to these things, the 5-year survival is 58% for patients with a HeartMate 3. With a HeartMate 2, it's not even that bad, but that's an old pump.
But
2-year survival is 79% in the HeartMate 3 group in this trial, overall survival.
So if we looked at it and we said we weren't going to put this in, you said it's abysmal without it. So this survived, just for our listening audience to understand, these are not relatively healthy people. These are really sick, we're going to die people.
These are the people who are at the extremes of advanced heart failure, who have failed all forms of medical therapy and are either trying to get it to be eligible for transplant or are not transplant eligible. So Mr. Lorenz, for example, is not a transplant candidate given his age, but this is still an option that can provide him time out of the hospital, freedom from heart failure, and hopefully, no one has a stamp on their foot, but hopefully this is something that he can get very comfortable living with for many years.
So what would his survival have been at 2 years without this HeartMate 3?
Well, I mean, medical therapy has come a long way as well. I don't want to denigrate the work done by my non-surgical colleagues, but it's still a fraction of what the survival would be for these patients. Well, like I said, from rematch, the optimal medical therapy group. So this was granted, it was 20 years ago, but this is on inotropes and all of the aggressive medical therapy. The 2-year survival was 8%.
Dr. Shaw.
So I would like to add, we did one study at KU, and we had one more center. We kind of observed 300 patients who were not candidates for LVAD for one reason or other. Mean survival was 5 months.
Yeah, so not very good. So this is such an incredible advance in therapy, and the technology, I expect, is going to only get better. So we're talking about really poor survival without this kind of thing, and then with an LVAD, much improved. So let's introduce some more important LVAD technology, or some terminology. Patients are often grouped into one of 2 categories: bridge to transplant or destination therapy. Now, I got to tell you, when I think of destination therapy, I think of a beach or something like that. But what you guys would talk to us a little bit about what bridge to transplant is and what destination therapy is. Dr. Shaw.
So bridge to transplantation. So sometimes patients come to the hospital very sick. We call them crashing and burning. To put them on the transplant list takes time, and then they have to wait. Depending on how high they are on the transplant list, it can take time, and we may not have that much time. Patients may have few days, to be honest with you. So in that case, we go for an emergent VAD, and once they are stabilized, then they can be transplant candidates and wait. They are stable and can wait for years to get their heart transplantation. Then destination therapy is the candidates who generally we think will not be transplant candidates for one reason or others. It can be smoking, they can have cancer which is in remission, age, sometimes we look into patients who are great. Our age limit is higher than the national age criteria, but we still will not transplant patients above 74, 75 years of age, and they are perfect candidates for LVAD.
So really, a bridge to transplant means we're going to get you to a transplant where we need some help doing that. And destination therapy means, yeah, transplant's not in your future, but this device can save your life and keep things going for a long time. So you've talked to us, you've already said a little bit about what some of the criteria are for transplant or not. So let's move on to the next thing. Let's talk again. Remember I said before it sounded kind of almost like a disco sound, a whirly. I mean, you could almost hear that centrifuge running. Let's listen to these sounds again now that we have a little better frame for the discussion. Okay, it sounds like a motor, or maybe to somebody who's dying of heart failure, that truly is music to their ears, right? Let's talk about music to their ears. So, Dr. Danner, how do you put that thing in?
There are a couple of techniques that you can utilize to put in. I would say that the majority of them are put in through a full sternotomy.
Tell us what that is. That's when you open up the chest.
That's the incision from basically here to the end of your sternum in the midline. So anyone who's had heart surgery will know that that's a pretty significant approach. The techniques that have been pioneered here and other places are to use sort of less invasive techniques. And for people like Mr. Lorenz who had previous heart surgery, we advocate a less invasive approach. It's certainly not a minimally invasive approach, but it still is a sternotomy where we make limited incisions on the upper part of the breastbone and also on the side of the chest, and we can put the pump in through that. It requires to go on the heart-lung machine, which is the machine that circulates the blood outside of the body and supports both the lungs and the circulation, and it's an extensive, very big operation. But for these patients, there are little, if no other options. So risk is an interesting thing that people talk about, but these are very high-risk procedures that are done. But nonetheless, I think we have excellent results here, and it shows what can be done when a team is dedicated to helping people that are even in this much of the extremes of their disease.
So, Dr. Shaw, why does an LVAD change your heartbeat? I mean, do you still have a heartbeat that's like you normally have a heartbeat, or what does it do to work together?
Yeah, it's a very good question. So, Dr. Stites' heart still beats. It also depends on how fast the pump is, what the speed of the pump is, how much blood it's sucking out of the heart. Generally speaking, we still have heartbeat, but it's masked by the LVAD sound. And in geek's term, we call this sound, by the way, LVAD hum. So hum kind of takes over the soft heart sound these patients have, but they still have their heart beating, and it depends on how much work LVAD is doing.
Yeah.
What will change is that it's not so much the heart rate. Like the ECG and the electrical signal of the heart will look the same relatively, but what you'll see is that the pulse can go away. So people tend to have either a very, very minimally palpable pulse or no palpable pulse at all.
So because the blood's just kind of more constantly flowing, is that what's going on?
No, it's a continuous flow pump. So for most of these hearts, the hearts are so sick that they no longer effectively distribute blood throughout the body. So the majority of the circulation is then taken over by the mechanical pump. And that is a continuous flow device. They have several relatively intricate models they use to try and simulate a pulse within the device. That's rather technical, probably not for this discussion, but the reality is that you essentially end up with almost or very minimally palpable pulse. You can Doppler it, but you can't actually feel it.
That's remarkable. So, Dr. Danner, the health system ranks second in the nation for a shorter length of stay following a heart transplant or an LVAD. Explain why we care about that. What does it mean? I mean, I would think, gosh, if you're not here long enough, do you get enough care? I mean, how do we look at that?
Well, it's one of the metrics that's tracked by all of the agencies that sort of evaluate our outcomes and things like that. It's only one of the outcomes that's relevant to heart failure surgery, but I think what it means is that any instance where we can get people out of the hospital sooner and back to their normal activities sooner is good for the patients, and it's good for the health system. I would say the lion's share of that work is done by our outpatient nurses, our rehab facilities, our people that are involved with managing the patients in the outpatient setting.
Because one really doing a lot of patient care on the outside.
Yes,
yeah.
and you know they need a good surgical procedure. They need a good ICU and in-hospital stay, and then afterwards, what gets them out early, and also really what the other metric is that we are concerned about are readmissions. What keeps that low is the work that's done by our nurses and colleagues in the outpatient setting.
Yeah, it's a remarkable story. Dr. Shaw, did you have something to add?
No, I think it's a marker of how good our surgical setup is, then how good the surgical setup is, and how good the rehab is. I think the length of stay depends on these three factors. How good when they go into surgery, they are already on very good meds, their volume status is good, they are functional, we kind of try to make them exercise. Then how good your surgical team is, how good the ICU is, and how much confidence you have in your rehab if you are sending them to rehab.
You know, one thing we didn't talk about is how hard are those tubes to manage? Like if I'm not particularly the most graceful guy in the world, I may get stuck and be like, am I going to pull that tube out of my heart and cause all sorts of trouble?
We have seen at the place I previously was here, a myriad of things that can go wrong with the driveline. And the driveline is basically the major Achilles heel of the current devices. So what everyone in the space is working on is a totally implantable device. And when that comes, that'll change the whole landscape of heart failure surgery, I think. But yeah, no, people close the door on their driveline, the dog eats their driveline, something happens. Well, sometimes
the driveline it's electrical. It's not the blood, it's the electrical.
It's the electrical connection to the power supply. Yeah. So when that fails, sometimes we have to change the pump. It's usually not that grave a situation, but there are some situations where an injury has occurred to the driveline, and it's...
So tug of war is a bad idea.
Sorry, tug of war is a bad... Yes, yeah. Driveline tug of war is not recommended.
Okay,
yeah.
So how do these people... I live longer. Do they live well?
Yeah, so if you look at what the sort of natural history of advanced heart failure is, what people have is they get admitted to the hospital, they get diuresed, they get discharged from the hospital, they get diuresed, and they eventually the frequency of that happening increases, and they get to the point where they go into the hospital and they don't come out. The one thing that one of the many things that LVAD's demonstrated is it keeps people out of the hospital, it improves their quality of life, the 6-minute walk test, the quality of life scores, and it gets people back to a near normal quality of life.
Are you going to airplane mechanics?
Right. I mean, if you're a deep sea diver, you can't do that, and these kind of things. But it's a reasonable quality of life.
It's not sure when you see these patients again, they're back, they're out of the hospital, their life back. They all want to give you a big hug. I'd want to give you a big hug.
Generally speaking, yes, you're right.
That is cool.
It's a drastic change in their life from not able to do most of the things they used to enjoy, now able to do most of the things they would like to do.
Are heart transplants going to become extinct when this technology gets so good?
I hope not.
He's like, what is my job going to be? All right, Jess, let's talk a little bit. You've been keeping an eye on the questions sent in via email. I bet you got a few.
I sure do. Alice has a really important question. Does the LVAD run on battery? If so, how long does the battery last, or can it be recharged?
Dr. Shaw.
Yes, absolutely. It runs on the battery. That's why patients have the drive line. I want to show you guys drive line. That's the one that comes out of the belly, and it's attached to the battery. Generally speaking, it can last 5 to 7 hours, and they carry a pack of 2 more batteries in case their power is running low.
So then you just kind of plug in.
Yes,
like you
it's
just
very
plug
simple.
in somewhere and you sit down and say, have a charge?
Absolutely. Okay, it's very simple, and patients are able to do it very fast.
So in the old terms, when people say, I got to go get a little recharge going, they really mean it in this case.
Yes.
Yeah. How long does it take to charge?
So it takes like half an hour to fully charge it, yeah.
All right.
Okay, so what's the difference between a pacemaker and an LVAD? Kay wants to know.
All right. What do you think, Dr. Dander, to help us understand that a little bit?
Sure. So they're both sort of procedures that are done. The pacemaker is designed to have wires that go inside the blood vessels, the great vessels, and insert into usually the right side of the heart in order to control your rhythm. So typically a pacemaker and sometimes a defibrillator can be put in to control your rhythm. The LVAD is a much more invasive, full, big surgical procedure that's designed to take over the pumping function of the left ventricle. So the left ventricle is the main pumping chamber of the heart, and it distributes the blood to the entirety of the body. And in the patients we deal with, that's failing. So the LVAD is essentially a pump that sits in the left ventricle and helps move the blood around the body.
And the pacemaker is really just helping your heart rhythm per se.
Correct.
It's not doing anything to pump outside of making your heart rhythm work better.
I mean, in simple terms, I think if you have a pump, a motor at home, pacemaker is if your wiring has gone bad. And LVAD is if the whole pump has gone bad and you need a new pump.
So if I got this LVAD thing in, can I go out and walk around pretty well or exercise or?
Yeah, people golf, people.
Absolutely.
The only thing you really can't do is submerge yourself in water.
That's probably a bad idea with all the electrical wires coming out of your chest, right?
That's right.
Okay. Jess?
Bruce is asking if a new model of LVAD comes out, then do all existing patients have to get new surgery?
Great question.
Great question. The short answer is no. There are some. There will always be new iterations in terms of the develop. We hope actually in the development of new mechanical assist devices. Recently, one of the other approved LVADs was taken off the market for complications, and so we have entered into changing out those pumps when complications occur. But it would not, in my estimate, be something that is done routinely if there was, say, the HeartMate 4 came out and everybody wants the newfangled thing, that we would put people through a surgery just to replace that pump if their pump was working fine.
So it seems like once the thing it becomes smaller and the batteries are different, and then you don't have all the kind of wires hanging out. That would be a reason to get the new cool stuff.
Right, but I'm not sure I would. It's a risk-benefit thing, right? I'm sure I wouldn't put them through another big operation unless we could demonstrate definitively that the new pump was better than the old pump, or that there was some reason to change out the old pump. But like I said before, I think that the next big change will be when they can get rid of the driveline and have a fully implantable device that's reliable.
Jess?
One more question. Jill wants to know, if an LVAD changes your heartbeat, then how do you measure blood pressure?
Okay, I was wondering the same thing.
It doesn't. Yeah, sorry. Go ahead.
No, it's not that complicated. We rely more on the Dopplers. Patients are trained to get their blood pressure, and we use the Doppler technique. They all have a Doppler at home. Just inflate their arm and check the mean blood pressure.
So what you're saying is the Doppler measures sound, really.
That's right.
As opposed to, they both measure sound. But in this case, I think it's like what we would call you can watch the blood go through the arteries with a Doppler, that flow is what you're looking at that point.
But it doesn't technically change your heartbeat at all. It changes your pulse. That's what it does more than
So talk to us about what that means, because that's
So the heartbeat is the sounds that are generated by the pumping of the heart. That is still there and would still be the same. It's just masked by how loud the sounds are coming from the pump. The blood pressure becomes something that for many patients, it's not like you have when you look at your blood pressure, you have a systolic, which is the higher number, and then a diastolic, that's the bottom number. The gap between that gets very narrow, and essentially you just measure what the average blood pressure is with the Doppler device. So your pulse goes away, but your heart rhythm is still intact.
Yeah, it's pretty amazing and the right side of the heart's still pumping away, right?
Absolutely.
Right.
So you do have a little bit of a pump function, just on the other side, not the side that's
right. It's actually absolutely essential that the right side still works.
Yeah. Okay. Jess, anything else?
I'm going to let you wrap it up.
Excellent. I love that. I want to ask Dr. Williamson another question. Dr. Williamson, masking. Now that this pandemic is over, do we need to still be wearing masks in hospitals?
So we do still wear our masks in patient carriers and hospitals, and we're looking at that all the time. But the short answer is yes. Now, out in the community, everyone makes their own risk assessment if they need to wear a mask based on their own risk factors for getting COVID and for what happens if they get COVID. But we have lots of very vulnerable patients around here. And so we want to make sure that we don't get COVID from them, we don't give them COVID or other respiratory diseases, RSV, flu. So for the short term, we absolutely will continue wearing masks in patient care areas, and we'll keep evaluating that. And I know essentially all the other hospitals in the metro area are doing the same thing.
Yeah, I think we're all doing it, right? We follow that with our CMO calls. But I think the answer, I totally agree. One of the things we've learned is that we can protect patients from disease. And when you have a highly vulnerable population, like people hanging out getting left ventricular assist devices, the last thing you need them to do is get COVID right before a procedure. So masking in the hospital still feels pretty important. So let's talk a little bit. This has been a great discussion. I'm always looking for, these are my favorite shows. I love Show Me the Science, and you know why I love it the most? I learn a lot. I come down here and I think, okay, I've got to be somewhat of a content expert, so I have to read a little bit. But more than that, I learn from you guys. It's the best, and I really appreciate your all being here. I know our listening audience really has enjoyed it as well. Let's get final thoughts from our guests. Dr. Dancher.
No, thank you very much for having us. I think it's important to get the message about what the therapies are for advanced heart failure out to the community, because historically anyways, there's been sort of this belief that there aren't any options, or the options are limited, or they're not very good. And I really think that the science is changing that impression, and I hope that locally and statewide that we start to look for opportunities to refer patients with these conditions so that we can help them.
Dr. Shah.
So I want to thank for this opportunity, and I think my last word will be on the patients that I'm more focused on, that's elderly and females. National data still shows we are not being aggressive, especially elderly patients who still have good quality of life, are functional but have heart failure. So I do want to get this message out there. If out in the community they have patients who are elderly, still have good quality of life, or females, which where national data also shows not doing enough LVADs, who qualify for that, refer those patients to us. As you know, our outcomes are excellent, and they will get some help for sure.
Such a transcendent change, really. Okay, Dr. Williamson, T. Willie.
Yeah, it was great learning about LVADs as well, and I think COVID numbers are definitely headed in the right direction, which is great, but we can't let our guard totally down, and still staying up to date with vaccinations and boosters as recommended are still the most important thing we can do to stay out of the hospital and prevent mortality.
I'm still impressed that people still get so upset about science. And you sit back and look at where we've come in heart failure, and I grew up in the era of, first of all, when I started, we still were doing rotating tourniquets, if that sounds barbaric enough, but we were, and putting ACE bandages around legs to try and squeeze the fluid back out. And now we've got devices that turn a mortality rate of almost 98% or 90% into a mortality rate of 20 or 30. That's just a remarkable treatment advance. And it's about people working together, and it's all about teamwork. You heard about the beginning, when patients have to get in the best shape possible for the surgery, and then on the outpatient side, with really so much of our nursing and case management staff taking over to help make sure patients have good outcomes. It's all about teamwork, and it's about science. And that combination is really amazing, and it can lead to transformative change, just as it already has for millions of Americans and people around the world. So science is your friend, and remember, as you go through the day and you hear all the kind of the chatter around it, think about this program. Think about what science has helped us do to save lives. That's why when I say live long and prosper, yeah, I'm talking about Star Trek. I'm also talking about you. You, Jess.
Me? Okay, I will. Dr. Seitz, what a great program today, and I learned a lot as well. Thank you so much.
Subscribe to our morning medical update and open mics with Dr. Stites podcast. Now everywhere podcasts are available.